Hello and welcome to HSE Antibiotic Prescribing Line series. Let us discuss one of the common conditions we face in primary care and out of hours.
Please note that this video is for educational purposes only, and your clinical decisions are your own responsibility.
Hello and welcome to HSE Antibiotic Prescribing Aligned series by Dr. Wala Adnan Ahmed. Let us discuss one of the common conditions we may face in primary care and in out of hours.
It's great to be diving into this. And honestly, if you're working in general practice or covering any pediatric shifts, this topic isn't just common. It is, well, it's practically the background noise of your clinical life. We are talking about acute otitis media, or AOM.
Absolutely. It's the classic bread and butter presentation, isn't it? But it's also one that comes with a surprising amount of emotional weight.
Oh, for sure.
You've got a distressed child, usually screaming, and a parent who hasn't slept in 2 days. The pressure in that room to fix it, which usually translates to give me a prescription, is just intense.
That pressure is real. And that's exactly why this deep dive is so important. We're looking at the HSE guidelines, and the mission today is really to separate that emotional pressure from the clinical evidence.
Right.
We need to figure out when that prescription is a medical necessity and when we might actually be doing more harm than good by writing it.
And to kick us off, I think we have to start with the headline statistic from the expert advisory group. I've read through the source material, and this number, it just stopped me in my tracks. It completely reframes the entire conversation.
It really does. It's the kind of statistic that should be, printed on the wall of the waiting room.
Yeah.
The data shows that 80% of acute otitis media cases resolve within 3 days without antibiotics.
80%.
Oh.
That is 4 out of 5 children. So if you did absolutely nothing but supportive care, the vast majority are going to be fine in 72 hours.
Precisely. And I think for a lot of clinicians, that number feels counterintuitive because we're trained to hunt for the bacteria. We look in the ear, we see a red bulging drum, and our brain just says infection, bacteria, antibiotic.
Right. We're trying to distinguish, is it viral, is it bacterial? But the guidelines make a really strong point here. They essentially say, stop obsessing over that distinction.
They do. They remind us that clinically distinguishing between a viral and a bacterial cause in AOM is notoriously difficult. You can look for the bulging, you can check the temperature, but often these pathogens just coexist.
So you've got a bit of both going on.
You might have a viral upper respiratory tract infection that creates the environment for a bacterial secondary infection. But the aha moment in these guidelines is realizing that it doesn't actually matter as much as we think. AOM is usually self-limiting, regardless of the cause.
So if we accept that 80% resolution rate, and we accept that we can't reliably tell the bugs apart anyway, our priority, it has to shift. The goal stops being eradicate the organism and starts being treat the child in front of you.
Exactly. We pivot from being infection hunters to being, symptom managers. The guidelines are explicit. The most important factors in management are pain relief and parent information.
Let's drill down into that pain relief aspect, because I think in the rush of a 10-minute consultation, pain relief often becomes a sort of throwaway line. We say, give them some Calpol, and then we spend the rest of the time debating the antibiotic.
We do. And the guidelines suggest we're getting this backwards. It's not just about suggesting analgesia, it's about prescribing a regimen of adequate and regular analgesia. We're talking about paracetamol or ibuprofen, but the devil really is in the details.
And it's not the drug choice.
No, the most common failure point here isn't the drug choice, it's the dosing.
And this is where the guidelines get specific about weight versus age.
This is huge. We've all seen the bottles that say age 2 to 4, but the variation in weight of a 2-year-old compared to a 4-year-old is massive. If you have a robust, heavy 3-year-old and you're giving them the lower end an age band dose, you are essentially underdosing them.
You're not hitting the therapeutic window.
Not even close. So the child is still in pain, the parent assumes the medicine isn't working, and their anxiety just spikes.
And that anxiety drives them right back to you demanding antibiotics because the Calpol didn't touch it.
Exactly. The HSE guidelines explicitly reference the weight-based dosing charts. There are PDFs available. The takeaway is, put the child on the scales. Dose by mass, not by birthdays.
It effectively turns pain management into a precise clinical intervention rather than just home advice.
It does. If we get the pain under control, the child sleeps. If the child sleeps, the parent sleeps. And suddenly, that desperate need for an antibiotic, it just evaporates.
Yes, such a vital clinical pearl. Treat the pain to clear the clinical picture. Okay, so we've optimized the analgesia, we've weighed the child, we have the parents on board with a regular dosing schedule.
Yeah.
Now we have to make the decision. to prescribe or not to prescribe. The guidelines seem to push for a default setting of no.
That's the baseline. The recommendation for the majority of children is to consider no antibiotics. But obviously, medicine isn't an assembly line. We have to stratify the risk. The guidelines break the patients down into two clear groups.
Okay, let's unpack those. Let's call them Group 1, the wait-and-see group,
Right.
and Group 2, maybe the might-need-it group. Who fits into Group 1?
So Group 1 are your candidates for no antibiotic or maybe a backup prescription. This includes pretty much all children aged 2 years and older, but, and this is a crucial detail, it also includes children under 2 years, provided the infection is unilateral.
Unilateral meaning just one ear is affected.
Correct. If you have a child under 2, but it's just the left ear, and this is key, there's no otorrhea, no discharge leaking out, they still fall into that hold-off category.
That feels like a significant distinction. I think there's a tendency in primary care to just treat anyone under 2 automatically because they feel more fragile.
There is, but the evidence suggests if it's one-sided and dry, they're safe to wait. The systemic load is generally lower. And for this group, the primary tool isn't a hard refusal, it's the backup prescription.
I'm a huge fan of the backup prescription. It feels like it solves the psychological problem as much as the medical one. How do the guidelines suggest we frame this to the parent?
The framing is everything. You write the script. You physically hand it to them. But the instruction is, keep this. Continue the pain relief we discussed. If there is no improvement in 3 days, or if they get significantly worse before then you can fill it.
It empowers them. They aren't leaving empty-handed. They have a plan B in their pocket. It prevents that 2.0 a.m. panic where they feel helpless.
Exactly. It turns the parent from a passive recipient of care into an active manager of the condition. And, studies show a huge number of those prescriptions never get filled.
Right.
Their parents just need the security of having it. It shifts the dynamic from a negotiation to a partnership.
Okay, so that's Group 1. Now, who falls into Group 2? Who are the kids where we actually need to lean forward and consider immediate treatment?
Group 2 are the patients who might benefit from immediate antibiotics. And I want to stress the word might. It is not a mandate. This group includes children under 2 years of age who have bilateral infection. So both eardrums are red and bulging.
Double trouble.
Right. And the other category in Group 2 is any child, regardless of age, with otorrhea secondary to a perforated eardrum. If the ear is leaking, the risk profile changes. The barrier is breached.
Okay, so under 2, with both ears involved, or anyone with a perforation.
Yeah.
Those are the flags. But you said even here, it's not automatic.
The guidelines are very nuanced. They say immediate antibiotics are an option, but so is a backup prescription depending on your clinical judgment.
So it gives you an out.
It gives you permission to use your brain. If you have an 18-month-old with bilateral red ears, but the child is sitting on the floor, playing with toys, eating well, and the fever is controlled, you don't have to hit them with amoxicillin immediately. You can still watch and wait.
That is really liberating. It moves us away from algorithm-based medicine where A plus B must equal antibiotic. It puts the clinician back in the driver's seat.
And we have to ask ourselves, why are the guidelines pushing us so hard to hold back, even in these riskier groups? It comes back to the clinical outcomes.
Right, the efficacy. We mentioned the 80% resolution rate earlier. But what about the kids who do get the drugs? Surely, if we give them antibiotics, we're speeding up that recovery.
You would think so, wouldn't you? That is the assumption. But the evidence paints a very different picture. It states that antibiotics make surprisingly little difference to the number of children who improve, or the time it takes to improve.
Really? So we're not cutting the illness duration in half or anything like that?
Not even close. We might be shaving off maybe 12 to 24 hours of symptoms at best for a subset of children. For the vast majority, the illness runs its course on almost the exact same timeline, whether they take the antibiotic or not.
That is a tough pill to swallow, pun intended. Because we use antibiotics as a tool to do something. But I know what every clinician listening to this is thinking. We don't just prescribe for the pain duration. We prescribe because we are terrified of complications. We're worried about the M word.
Mastoiditis. That's the specter in the room. It sounds scary, it is serious, and it is the reason many of us overprescribe. I don't want to be the doctor who missed it, but we need to look at the actual numbers. The HSE guidelines provide a number needed to treat an NNT for mastoiditis.
Okay, walk us through this. How many kids do we have to treat to stop one case?
The number is staggeringly high. To prevent one single case of mastoiditis, you would need to treat 2,504 patients under 20 years old with antibiotics.
2,504? Wait, just say it again.
2,504.
Wow. Let's put that in perspective. If you're a GP seeing a few ear infections a week, you could work for decades and never see that one case you prevented.
Exactly. You would have to sit in your surgery and prescribe amoxicillin to every single red ear you saw for years and years just to statistically stop one complication. And the kicker is, mastoiditis is rare with antibiotics too.
It's not like the drugs are a magic shield.
Not at all. The protective effect isn't absolute. But there's another side to this ledger. If we treat 2,500 kids to save one from mastoiditis, what are we doing to the other 2,499?
We aren't just giving them sugar pills. These are active drugs with side effects.
Precisely. We are exposing them to adverse effects like diarrhea, nausea, vomiting, rash. These are common. So, in our attempt to prevent a statistical anomaly, we are actively causing gastrointestinal distress in hundreds of children.
That's the trade-off. We're trading a rare risk for a guaranteed common harm. When you frame it that way, it changes the conversation with the parent, doesn't it?
It changes everything. It moves the conversation from, why aren't you giving me antibiotics, to why would I want them?
And just to round out the what it doesn't do list, what about long-term issues? Parents worry about hearing loss or recurrent infections. They think if we don't zap the bug now, it'll come back later.
And the evidence is clear there too. Antibiotics have minimal impact on recurrence, short-term hearing loss, or preventing eardrum perforation. Treating this infection today does not save the ear for tomorrow.
So we aren't saving their hearing, and we aren't stopping them from getting another ear infection next month. It really just reinforces the symptom management approach.
It does. It keeps the focus on the here and now.
While we're on things that don't work, let's clear out the medicine cabinet. Parents will ask about everything. Can I give them a decongestant? What about antihistamines?
This is the do not do list. The guidelines are explicit here. Decongestants, antihistamines, and corticosteroids have not been shown to be effective in AOM.
I suppose the logic from the parent is sound. The ear is blocked, let's unblock it. But the anatomy just doesn't respond that way.
Exactly. The eustachian tube dysfunction in a child isn't typically something you can fix with an over-the-counter decongestant. You're just adding chemical load for no clinical benefit. So, advise against them. Keep it simple. Analgesia, hydration, comfort.
Let's pivot to safety netting. Because if we are sending these families home without a prescription or with a backup script they might not use, we need to be sure they know when to worry.
No, and managing expectations is half the battle here. We need to be honest about the timeline. We tell them, most children get better in 3 days. However, seeing symptoms linger for up to 1 week is within the range of normal.
So don't panic on day 4 if they're still a little grisly.
Right. But we also give them the red flags. They need to return immediately if symptoms worsen rapidly, if the child becomes systemically unwell, lethargic, or if there is a sudden high fever after a period of improvement.
And the guidelines mention a specific resource for this, right? The Respiratory Infection Information Leaflet.
Yes, for patients aged 3 months and above, I think this is a vital tool. Giving the parent something physical, a high-quality official leaflet, it acts as a psychological substitute for the prescription. They're walking away with something.
It validates their concern. It says, we're taking this seriously, here's the plan, rather than go home, it's nothing.
Exactly. It professionalizes the wait-and-see approach.
All right, let's shift gears. We've done the wait and see, we've used the backup script, but let's say the child falls into the treat category. We are reaching for the prescription pad. What's our weapon of choice?
First line is amoxicillin.
Simple. And the duration?
5 days. This is the standard. For routine AOM, 5 days is sufficient.
And for the penicillin allergic kids?
Then we switch to clarithromycin. Again, a 5-day course. But this is where we need to pause for a second. Macrolides, like clarithromycin, they have a different interaction profile than amoxicillin.
Right, the interaction table. There's some big ones to watch out for.
The big one is anticoagulants, warfarin, DOACs. Now, obviously, it's rare to see a toddler on blood thinners.
True, but AOM isn't just for toddlers. You could be treating a young adult or a child with a complex cardiac history.
Precisely. You also need to check for statins if you're treating an adult. The habit of check interactions with macrolides should just be ingrained in us.
Okay, so amoxicillin is plan A. Clarithromycin is plan B for allergies. What if plan A fails? The child has been on amoxicillin for 48, 72 hours and nothing's changing.
Then we escalate to second line. That would be coamoxiclav.
The big guns. Also 5 days.
Yes, a 5-day course is standard there too.
Now, I noticed a detail in the guidelines about duration exceptions. You said 5 days is the rule, but is there ever a time we go longer?
There is. We have discretion here. A 7-day course may be reserved for those with more severe or recurrent infections. So if you have a child who's had multiple AOMs or clinically they just look significantly more unwell, you can extend that course to 7 days.
It's good to know we have that flexibility.
Absolutely. And before we move on, the guidelines do list some key resources because, let's be honest, nobody memorizes every single drug interaction.
Nor should they. That's what databases are for.
Exactly. The guidelines point us to the HPRA website, the Irish Medicines Formulary, or the BNF for children. If you have a child with renal impairment or complex medical history, don't guess. Look it up.
So, let's try to bring this all together. What does this deep dive effectively mean for the clinician sitting in their office tomorrow morning when that first screaming toddler comes in?
I think it means a fundamental shift in mindset. We need to move away from the idea that AOM equals antibiotic deficiency. The management of acute otitis media is primarily about two things: pain control and safety netting.
It's about being a pain management consultant first and a prescriber second.
Yes. It's about using weight-based dosing to make the child comfortable. It's about trusting that 80% resolution rate. And it involves using the backup prescription as a tool to bridge the gap between doing nothing and over-medicalizing.
It's about having the confidence to say no or not yet, knowing that the highest quality evidence supports that decision. You aren't withholding care, you're practicing evidence-based safety.
And treating the child, not the anxiety in the room.
That's the hardest part, but the most important. Managing the parent's fear is often the real clinical challenge here.
It is, but when you explain the trade-offs, the diarrhea, the lack of efficacy, that NNT, most parents get it. They want what is best for their child, not necessarily just a bottle of pink medicine.
I want to leave everyone with a final thought, something to mull over. We talked about that number needed to treat for mastoiditis, 2,504.
It's a haunting number.
It really is. It
Yeah.
sort of encapsulates the dilemma of modern primary care. If we are treating thousands of children to save one from a rare complication, but in the process, we are giving hundreds of those children diarrhea, nausea, and contributing to global antimicrobial resistance. How do we ethically balance that? How do we effectively communicate to a worried parent in a 10-minute consultation that doing nothing is actually the safer, more active choice?
That's the art of medicine, isn't it? The science gives us the numbers, 2,504, but the art is the communication. It's how we translate that data into trust.
Well said. We will leave you with that challenge. Check the show notes for the links to the weight-based dosing tables. They are a game changer for your practice if you aren't using them already. Thanks for listening to this deep dive into the HSE guidelines.
Thank you. Stay curious and safe prescribing.
Please don't forget to hit the like and subscribe for more educational videos like this.